Good afternoon, everyone, and welcome to today's webinar, our Medicare Advantage Organizations Being Honest with Providers, Top 5 Lessons about Risk Adjustment Data in Medicare Advantage. Today's speakers include Frier Levitt co-founding member, Jonathan Levitt, and Senior Associate, Jason Silverberg. Before we get started, I just wanted to note that all lines have been muted. I also want to remind you about the Q&A tab of your screen. Please feel free to type in your questions throughout the webinar today. We will wait till the end of the presentation to answer those, but we'll be sure to get to all of them, whether it be during this webinar or an email following today's presentation. The webinar is also being recorded and will be sent to you by the end of the week so that you can watch in case you missed anything and can share with any colleagues who you may think benefit from the information. So without ado, I'm pleased to turn this program over to Mr. Levitt.
Thank you so much. Appreciate it. My name is Jonathan Levitt. I co-founded the firm about 21 years ago, and I'm very excited today to be presenting. I am a trial attorney, and we do have cases in the space of Medicare Advantage risk litigation. We also have a regulatory department that helps providers, and we'll describe who those providers are in another slide, help negotiate these contracts. I'm also really excited today to talk about these topics. The OIG came out with a report in April 2021 entitled Medicare Advantage Compliance Audit of Diagnosis Codes that Humana Inc. submitted to CMS. And they literally just did an analysis. And Jason and I have really gone deep down the road of this type of analysis before. And it was very interesting to see this report come out. I'm really excited to do this. Really, most of this presentation is Jason's. I do want to thank our marketing department for putting together wonderful slides. Lauren and Amy and Brianna, very appreciative. Jason Silverberg is kind of a unique lawyer. He comes from the Attorney General Department in New Jersey, and he is extremely knowledgeable about healthcare risk adjustment and the relationship between providers, Medicare Advantage organizations, CMS, and how the data flows. Jason is also multilingual. Interesting fun facts about Mr. Silverberg. He's cringing right now, but Mr. Silverberg is multilingual. He could give this presentation fluently in many different languages, and he also speaks the language of Medicare Advantage risk adjusted litigation. So I'm really excited to be doing this with Jason. Obviously, there's a legal disclaimer. It's not legal advice, but you can read this. A little bit about the firm, and you can read this also on your own. We represent really the entire panoply of stakeholders in both healthcare and life sciences spaces. In the life sciences space, we represent manufacturers, some of the big three even, many big manufacturers, some of the big three wholesalers, some GPOs, some national alliances of pharmacies and specialty pharmacies and physicians. And we're involved with organizations, the ACOs, and state organizations of providers. Jason's background and my background are here, and it's both interesting to read on your own. But so we have certain objectives for this. This is really designed for practices, ACOs, IPAs, and other entities that are either in or considering getting into a payment or a risk adjustment payment arrangement with a Medicare Advantage organization, which we will refer to as an MAO in this presentation. So practices, ACOs, and other IPAs and other healthcare entities currently that have agreements, where we want to let them know you should be concerned. There is a possibility that you have been underpaid in your capitated arrangement. There's certain learning objectives here that we've really carefully thought through. We want you to understand Medicare Advantage risk adjustment, the fundies, the fundamentals, and Jason's going to really break it down. We want to identify where and how risk adjustment data can be lost. Can be lost in several different areas of where it travels between providers and clearinghouses and MAOs and to CMS and back. We're also going to offer some strategies on how to deal with suspected underpayments, which is really, we believe, a massive issue. So I'm going to just introduce a couple comments here. First of all, I just want to, there's this entire presentation really derives from an OIG report dated April 2021, which we have, it's linked on the bottom here. And I just want to, I'm going to read, I don't normally do this. I'm going to read, it's going to probably take about 1 minute. I'm going to read a section of this report from the OIG, the Office of Inspector General. It's just written so clearly by the OIG, and it really just sets forth exactly why the OIG did an audit of Humana. It says, under the Medicare Advantage program, MA program, the Center for Medicare and Medicaid Services, CMS, makes monthly payments to MA organizations according to a system of risk adjustments that depend on the health status of each enrollee. Accordingly, MA organizations are paid more for providing benefits to enrollees with diagnoses associated with more intensive use of healthcare resources than to healthier enrollees who would be expected to require fewer healthcare resources. To determine the health status of enrollees, CMS relies on MA organizations to collect diagnosis codes from their providers and submit these codes to CMS. CMS then maps certain diagnosis codes on the basis of similar clinical characteristics and severity and cost implications into hierarchical condition categories, which we will refer to as HCCs in this program. CMS makes higher payments for enrollees who receive diagnoses that map to HCCs. For this audit, we reviewed one of the contracts that Humana Inc. has with CMS with respect to diagnosis codes that Humana submitted to CMS. Our objective was to determine whether Humana submitted diagnosis codes to CMS for use in the risk adjustment program in accordance with federal requirements. And they found that, that Humana did not follow the rules, and there was $197.7 million net overpayment. And so, Jason, can you introduce, now they've read the background of why the OIG did this study, why don't you just set up the rest for us?
Sure. So everyone's taken an interest in the sort of big $200 million, almost $200 million overpayment number cited by the OIG. But what interested us was some snippets of text in the report where the OIG also found a series of underpayments, and in certain cases, net underpayments, as a result of their failure to have submitted diagnosis codes that they should have. And just by way of background to explain to you what this means really from a practical standpoint, the OIG effectively conducted chart reviews. They did a random sampling of charts corresponding to enrollees in a Medicare Advantage contract administered by Humana for the purpose of determining whether or not the diagnosis codes that were submitted by Humana to CMS were supported by documented evidence in the medical chart. And obviously, when we're talking about overpayments, it was the OIG's opinion that the codes in question were not supported by the record. Conversely, with regard to the underpayments, it was the OIG's opinion that the medical charts supported the submission of additional or more accurate diagnosis codes that were not submitted. And had they been submitted, as OIG notes in the report, there would have been additional monies paid to, or premiums paid, I should say, to Humana. So, John, if you go to the next slide.
Hey, may I just ask one question, Jason? I'll ask a couple of questions here and there, but if CMS paid more money to Humana, does that mean that Humana would have had to pay more money to providers?
Right. So let me pull back a bit and get back to John's discussion of the objectives of this webinar. This webinar really focuses, or it's built around what is often referred to as a global risk capitated payment model, and which is becoming more commonplace. And what that means is all the parties involved in the arrangement bear risk. So Humana bears risk in terms of, you know, whether or not it's going to lose money based upon the premium paid and the covered services, and as does the would a downstream provider who has a contract with Humana that in effect says, just as Humana's per member per month premium payments will be adjusted upwardly or downwardly depending upon risk adjustment factors, so too will the capitated payments in a sort of like percentage be adjusted upwardly or downwardly to the practice, which is why this should be of interest to practices participating or thinking about participating in this sort of arrangement.
Thank you, Jason. And I'll just emphasize one point you made, that these capitated arrangements are on the rise. So there are providers out there that haven't negotiated these contracts before and don't know some of the important terms that should be negotiated. So I'm going to just introduce this next slide for you, Jason. This is the cover page of the Medicare of the OIG's report that really gave rise to this webinar. We were literally going to do this webinar before this report came out. It wouldn't have been that much different, except for the fact that now we have an OIG report that kind of breaks it down. But so we're going to kind of go through a couple of the excerpts from the report. Jason, you want to lead us through some of these?
Sure. So I won't read everything, but I'll read you the important bits, the most important bits rather. First of all, the subtitle here speaks for itself. Diagnosis codes that Humana should have submitted but did not submit to CMS. This is from OIG, the Office of the Inspector General. And they go on to state that Humana did not submit all of the correct diagnosis codes, and that there were an additional 15 HCCs from 9 sampled enrollees. And when I say enrollee, I'm talking about a Medicare Advantage member, a patient, in effect, for which the medical record supported diagnosis codes that Humana should have submitted but did not submit to CMS. And these errors cause underpayments from CMS to Humana. They also note that these errors occurred because Humana's policies and procedures to prevent, detect, and correct noncompliance with CMS's program requirements as mandated by federal regulations, which we'll touch upon, were not always effective. So
I'm just gonna state that such an obvious statement, but that you've already said, but I want to emphasize it, and that is every provider out there should understand that maybe not every one of their diagnosis codes is making it to, although it makes it to Humana, it might somehow not make it to CMS, and therefore they're not going to get paid that incremental additional premium associated with that more sick member.
Right. And before we move on, I just want to mention an important point about the report. In our opinion, the report doesn't make it possible to discern whether some of the diagnosis codes that should have been submitted but were not submitted was the result of the practice in question failing to submit the code, which can also be an issue where you're trying to ensure that you're getting the full value and the full capitated revenues that you're owed under these sorts of contracts.
So the next slide, Jason, I'm sorry, were you done with the previous slide?
Yeah, go ahead, John, sorry.
Okay, no, I was just gonna ask, so the next slide is, does this OIG report imply that there's any kind of regulatory violation by the MAO?
Yes, so yes, potentially. The basic rule That those are the words used in the actual regulation statute. For risk adjustment data submission by MAOs to CMS is critically important. And it says, in effect, well, it actually says each MAO must submit to CMS in accordance with CMS instructions the data necessary to characterize the context and purpose of each item and service provided to a Medicare enrollee by a provider, supplier, physician, or other practitioner. So, in other words, MAOs are under a legal, statutory, regulatory obligation to submit all diagnosis codes, risk adjustment related information for a patient. And it makes sense why this would be the case, because CMS, after all, is paying monies out of the Medicare Trust Fund. And it wants to make sure that when it calculates a risk score, which we'll talk about later, and then from that issues a premium payment to the MAO, that they're not wasting their money, that they're not overpaying, or that they're not underpaying for that matter, to ensure that the patient gets the, is fully covered. The next provision here goes back to what I was talking about in the previous slide. It's 42 CFR 422-503. It requires MAOs to adopt and implement effective compliance, an effective compliance program, which must include measures that prevent, detect, and correct noncompliance with CMS's program requirements. In effect, this is one of the bases, from my understanding, for which the OIG concluded that there was an overpayment, that there were problematic overpayments here. In essence, they're saying that Humana's internal protocols and procedures were not sufficient to ensure that diagnosis codes not supported by a patient's chart were not submitted, or vice versa. Diagnosis codes supported by a patient's chart, were submitted. And finally, to highlight the importance of this requirement, there's 42 CFR 422.254L, and it says, effectively, MAO, CEOs, or CFOs, or designees must certify as a condition for payment under Medicare Advantage to the, quote, accuracy, completeness, emphasis on completeness, and truthfulness of relevant data that CMS requests. Such data includes specified enrollment information, encounter data, and other information that CMS may specify, end quote. So, in other words, Humana, it's not just a matter of an MAO potentially losing money for itself and its downstream contracted providers. There's a regulatory obligation and duty on the MAO's part to submit complete and accurate data. And if they fail to do so, but have certified otherwise, there are consequences.
So Jason,
yeah.
one comment I have here, obviously all these rules, I mean, you see the word data appearing in HCCs and diagnosis codes. There's so much data involved in this type of arrangement that any audit by a provider of an MAO and any litigation by a provider group against an MAO, I just want to comment that it is always necessary to have a healthcare data scientist who has a literal subspecialty in diagnosis codes, and our firm Frier Levitt has dealt very closely with some of these healthcare data scientists. Question for you, Jason. We've talked about the role of and all the obligations of a Medicare Advantage plan, but what about a provider's obligations?
So provider obligations are affected by the same regulations, in effect, that are applicable to MAOs. And that's because generally it's going to be by contract. The downstream providers are required to submit, quote, complete and accurate risk adjustment data as required by CMS to their MAO. That's from a regulation where CMS discusses the contents, suggest some portions of which are suggested, some portions of which are mandatory, of an MAO downstream provider contract. So obviously this is important for a provider for two reasons. Number one, from a regulatory standpoint, you need to be sure that you have protocols and SOPs, standard operating procedures in place, proper training for your physicians or other professionals coding to ensure that your submission of diagnosis codes are complete and accurate. That could be a technical violation of your contract if it's not. Also, obviously, to the extent there may be underreporting of diagnosis codes, you're just shooting yourself in the foot, because that will likely result in a patient risk score not being upwardly adjusted as it should be, and therefore you losing out on additional capitated revenues.
Jason, any developments in the shared savings arrangement marketplace?
Yeah, they're sort of anecdotally. I've heard that, there are payers that are beginning to consider swapping standard value-based, shared savings agreements based on reduction of cost and utilization for contracts that look more like global risk capitated contracts, be it in the Medicare space or potentially even the commercial space. So it's just another reason it's important that providers in this space or thinking about being in this space educate themselves.
Jason, someone asked the panelists a pretty interesting question. I'm going to try to address it. They basically say that some HMO contracts, and they give a specific one, have a risk score of only 0.8 according to CMS data sets. How is this possible when the average MA member risk score for the same county is over 1.2? Can you just address, first of all, the risk score of 1.0, what that means, and being below it, what does that mean for premiums? Being above it, what does that mean for premiums? And could just quickly, because I don't want to fall too far behind here, can you quickly address it?
Yeah, and I'll touch upon the concept of a risk score again later. I can't speak to the commentator's specific reference to that contract and that risk score, but hypothetically, problematic coding issues could result, in theory, in a reduction in a patient's risk score. The normalized risk score pursuant to CMS's normalization adjustment factor that they play with and apply every year is 1.0. So, below that, the higher you go, sicker the patient. The lower you go, less sick the patient. So it is, things like that could be red flags. Again, I can't opine on that specific example, but
And obviously this person's asking because a risk score of less than 1.0 means they're getting paid less per member per month, right, Jason? Okay, so why don't we go to this next slide, Jason? Is Humana the only one that's not maybe perfect in their MAO duties in regulatorily?
No. There's been a number of OIG reports that touch upon the issue of MAO overpayments. They're understandably, the government is more focused on the overpayment portion because that's what takes money out of their pockets, less so the underpayments portion, which for purposes of this discussion could take money out of the pockets of the providers. The government tends to be less concerned about that than taking money out of their own coffers, obviously. But there have been other reports that touch upon the issue of underpayments. For example, in February, OIG made findings that there were sort of regular, if not systematic, underpayments. The quote here is for 4 enrollee years, the MAO failed to submit proper diagnosis codes for a particular condition, which was supported by the medical records, causing underpayments for all 4 enrollee years. So again, it's not possible, as I noted before, to discern from that report whether or not that's a result, whether that's solely the result of an issue with the MAO's policies and protocols, or whether that could also have been, at least in part, a result of a provider's failure to fully capture the data it should have submitted.
Okay. So what does it mean for a provider practice from a practical standpoint? And can you also just address what kind of providers participate in Medicare Advantage?
Yeah, I mean, any sort of provider really can participate in Medicare Advantage. The sort of global risk capitation model, from my understanding, is generally more often found in the primary care space. And it's also often found in connection with entities like IPAs and ACOs. With regard to, with regard to the risk adjusted payment models, obviously fee for service could apply to really any sort of provider generally. But what this means is that practices who are thinking about getting into these payment arrangements or are already in these payment arrangements need to do some due diligence to make sure they're not leaving money on the table. We'll talk about some more of this later, but they should consider running a risk adjustment data checkup to ensure that they understand how a diagnosis code gets from the initial point A, which is the physician-patient encounter, all the way to CMS. You should be sure you know how you understand that pathway. And you should also be sure every step along the pathway has been reviewed. You need to make sure your physicians are fully educated on what is an appropriate what is appropriate coding. You don't want them not highlighting codes that could affect the patient risk score. Same thing for other your billing people or your coders. You want to make sure that they're up to speed on this stuff. And you should also have your contract with your MAO reviewed by counsel, highly recommended. This will help you determine whether you may have the ability to audit your MAO, just to say, to get access to the data it has relating to your practice, which has been submitted to CMS or received by CMS, which is really generally going to be the gold standard, not counting direct from CMS reports itself, of data necessary to perform the sorts of data reconciliations that will allow you to have a reasonable degree of confidence that you're being properly paid.
So I think this next slide, I mean, we'd like providers to be familiar with these concepts, and you have to ask some questions. Do the physician groups and all the professionals in your practice understand the whole life cycle of a diagnosis code? So someone asked the question earlier, why is the score less than 1.0? Why is it 0.8? The reasons why could be poor provider documentation, poor coding, possibly favorable selection by the MAO of different data sets. But you should be aware of reasons why, how the diagnosis codes get from a practice to the MAO, from the MAO to CMS, and then back. And we're going, because CMS generates risk scores based on these diagnosis codes received. So we're going to talk a little bit about the journey of a diagnosis code. Jason, tell us briefly about a diagnosis code and ICD codes.
Yeah. So one thing first, just getting back to the the issue of a risk score below 1. One of the things that you should consider in determining whether or not that's really a red flag or not, it need not be, is the demographics of your patient population. If your practice deals with very sickly patients, and you have a risk score that really is for a 20-year-old athlete, then, you know, that's a red flag, just as an FYI. But it's not necessarily, you know, if you see that risk score, it doesn't necessarily mean that there's inaccuracies.
Okay.
But,
So
yeah.
tell us about a diagnosis code,
Sure.
ICD-10 codes.
Sure. So DX code is sort of the colloquial way to refer to diagnosis codes, which generally refer to ICD-10 CM codes, which are sort of the fundamental building blocks for the risk adjustment arrangement. The ICD code, as we'll discuss below, is in effect the ICD. There are tens of thousands of ICD codes, and they each refer to a specific diagnosis. And these are the codes that are coded as a result of physician-patient encounter, and ultimately submitted to an MAO, often through, you know, through the intermediary of a clearinghouse.
So Jason, what is an HCC, which is mentioned like literally in the very summary report by the OIG why we did this audit? They talk about an HCC. What is an HCC?
Right. So while there's like 70,000 ICD-10 CM codes roughly, then there's about between 9,500 and 10,000, I think, codes, ICD-10 CM codes that map to HCCs. The hierarchical condition categories, HCCs, were developed by CMS in partnership with others, I believe. And in effect, it's a categorization system that groups together clusters of related medical diagnoses, particularly and medical diagnoses that tend to have a similar costliness associated with it. And you know, depending on the model, the CMS HCC model you're looking at, there can be between 79 and I think 86 HCCs. I think. Oh, thank you from the audience. Developed by Boston Brandeis University in the 1980s. Appreciate that. Interesting fact. I believe the current version is version 24, and I think that there are 86 HCCs. So every ICD code maps to an HCC.
So
there are multiple.
I'm sorry, Jason, go ahead.
Yeah. So there are multiple. Obviously, given the thousands of ICD-10 CM codes and the comparatively very few number of HCC codes, there can be multiple ICD-10 CM codes that map to the same HCC. And each HCC carries with it sort of like a weighted risk factor that is applied to a patient's risk score. So in effect, when the ICD code triggers an HCC, that weighted number associated with the HCC is generally, it's going to be tacked on to the patient risk score. So it's going to go from 1 to 1+, and that's going to increase the premium payments down the road.
Jason, in light of some time constraints, I think we should, can you talk briefly about the life cycle of the diagnosed code in the global risk capitation model? And obviously, you know, people we'll send these slides out to anyone who attends, and there's a lot we could talk for half an hour about this, even just this one slide, but maybe you just give us a broad overview of the life cycle.
Sure. So as I noted earlier, point 1 in the upstream path of a DX code to CMS is the physician-patient encounter, because after all, we're talking about diagnosis codes, and diagnoses they are recognized by the physician, and they are reflected in the patient chart resulting from the physician-patient encounter. Generally, the codes, which may be sort of dealt with, aggregated and packaged by a larger practice management system, or maybe their internal IT departments. Some of the larger ACOs may have that. It'll then go very often to a clearinghouse. And clearinghouses are basically way stations for this enormous amount of DX data coming from providers and going to MAOs. And they aggregate, process, and package the data for submission to the MAO. The MAO reviews the DX code and applies edits and processes the data, pushes it further upstream to CMS. CMS processes the codes through either its risk adjustment processing system, which is effectively being phased out this year fully, or the encounter data processing system, which is taking over. And if you go to the next slide.
So just real quick on this slide, where in this life cycle is the most opportunity by an MAO, if they wanted to kind of play games to the detriment of a provider?
Right. So, and we'll hit this later on, but generally, obviously, the provider has access to his own data, right? There's no question there. And generally, the clearinghouse is not going to have an issue. There's generally not going to be any sort of motivation that I could think of for a clearinghouse to refuse to provide you with copies of your data or the reports it's submitted to an MAO, right? So that's all relatively transparent. It becomes less transparent and really opaque once the data is in the hands of the MAO and CMS, because to my knowledge, there's no regulation or statute that requires an MAO or CMS, in fact, to provide the reports that go between the MAO and the CMS, of which there are many.
Thank you. Okay, so continuing on the life cycle of the diagnosis code.
Right. So, doing this as quickly as I can. Effectively, once it runs through this, the DX codes run through CMS's processing systems, either RAPS or EDPS. The ICD codes contained in the data trigger HCCs, I guess using CMS's algorithms. And as I said, each HCC has a weighted risk, which is then added to the patient risk score. And that could, depending on what it is, it can either upwardly or downwardly affect the patient risk score. Then once this is all shorthand, obviously, but once there's a patient risk score, which is technically referred to in the law, in the regs, as a risk adjustment factor, that is used as like a multiplier and applied to a base rate premium, which is calculated by CMS based upon MAO bids, and which can vary geographically, but effectively the patient risk score is multiplied by these pre-established base rates, and from there you have a dollar figure representing basically the premium payment for the MAO for the patient in question.
And then there's also the life cycle, continuing life cycle of the diagnosis code. There's also, once CMS has the information, it then does a risk adjusted per member per month payment to the MAO. The MAO receives that per member per month payment and determines a percentage breakdown in its contract with downstream provider. And then the provider, the MAO, reviews and processes the data, kind of editing some things and sending it back to the provider. I think every provider should understand that they have the ability, potentially based on the contract, to audit the data that the MAO has, and potentially to even look at the data that CMS was given by the MAO. These are important things that everyone should be aware of, and they should attempt to negotiate in their contract. A contract between a provider and the MAO in it, whether it's a capitated model or shared savings, should have proper audit provisions that allow the provider to do an audit.
I
So,
would just,
yeah,
John, if I may, if you
please.
go back to the previous slide, looks like there may have been a few typos here. Some of this language actually refers to DX processing, but as you noted, it's a relative, the payment flow is relatively simple. CMS issues the premium payment per member per month premium payment to the MAO. The MAO looks at his contract with the provider, the global risk capitated contract. It sees what percentage is owed under the contract, and it pays that downstream as a capitated payment to the provider.
Okay. So the next is, I think, and I could just do this one quickly, Jason, but the next question we really ask providers is, do you have your own house in order? You have to know what you've upstreamed from your practice to the MAO. You have to look at diagnosis codes, because you understand they can be lost in this life cycle that we've gone over. Does your practice have controls in place, both financial controls and regulatory controls, to ensure that the right diagnosis codes are submitted? Again, what the very first question was asked in here is why is my practice have a contract that has less than a 1.0 risk score? This is directly on point here. You have to make sure that your medical records are appropriate and your codes are submitted correctly. People have to really do an internal audit, and they have to have professionals, maybe even healthcare data scientists, to really look at their diagnosis coding. And you could also consult with the EHR vendor. We have experience here that EHR vendors sometimes are protecting themselves. They want to, when questions are asked by providers, they sometimes hide errors, and they don't want to, they don't want the provider to know when they've made mistakes. So, so EDI clearinghouses, maybe Jason, just quickly address the EDI clearinghouse. And
yeah, so generally, very often practices will have like a portal to a clearinghouse where they submit their DX data. A well-known clearinghouse is Valuebased LLC. As I noted before, they don't have the same sorts of self-interest that an MAO might have in withholding information from the provider. So they're a good place when you're running these internal audits to request copies of data from, to try and run an internal reconciliation against your practice's internal data and the data from the clearinghouse, and specifically the data from the clearinghouse that was submitted to the MAO. So you can compare what was submitted to the MAO with your own internal records. And if there's a delta between the two, there may have been an issue with the clearinghouse. And that's something obviously that needs to be addressed, because it's another place where data can be lost.
Okay. The point of this next slide is, when we talk about black box, what do we mean? What we really mean is that once data leaves your practice and goes to the MAO, there's a ton of work that goes on between the MAO and CMS. There's all kinds of reports that are getting of diagnosis data that's being sent from the MAO to CMS and back. You don't know what's happening behind the MAO, but you do have the ability to audit. I think that's really the point here, to understand that you don't know what goes on behind the scenes, and it's not always correct. Jason, can you just this slide kind of speaks for itself, but maybe you could just kind of explain what it is. And okay.
Yeah, so just to sort of illustrate the black box that we're talking about, we note that there are in the RAP system, again, which is being pretty much fully phased out this year, there are multiple and really key reports that are generated by CMS and sent to the MAO. And in the illustration here, you see the highlighted, this is from a CMS website, the highlighted language where there's an asterisk, noting that these reports are returned to the MAO organization, the MAO. They're not provided to the provider. And these reports include some really key information. Model output reports, for example, report all the HCCs used to calculate a beneficiary's risk score. And your MAO and not you is in control of this. And that means you have to take your MAO's word that the risk score they're telling you you're being paid on is in fact the risk score that are in these reports to which you have no access.
And I would just add to that when we have litigation involving these topics, as you've highlighted there on the slide, these reports files are returned to the MAO. And one of the things we do is we try to get those reports so we can verify and not just trust. So continue with the black box comment, Jason. What can a practice do?
Sure. So first of all, the practice, it depends on a lot of this depends on the contract. Certain MAOs will provide limited data sets to providers, or will allow limited access to data sets to providers. But again, you're taking the MAO at its word that these reports, which will generally purport to be as accurate as the reports that go between the MAO and CMS and the MAO, but you have no way to know that for sure. But in either case, you're permitted to, if you have access to these records, it would be advisable to take them and reconcile them against your internal practice data or the clearinghouse's practice data to look to see whether or not there's a delta, which is to say whether or not the reports from the MAO indicate that DX codes that should have been submitted were not submitted by the MAO.
And we have a very, very smart, experienced a person who has sent the message to the panel saying, his name is Richard Lieberman. Shout out to Mr. Lieberman. He says, since the RAPS is effectively gone as of this year, the key EDPS report that providers need is the MAO-004 report. So just throwing that out there. So Jason, can providers audit their MAO?
It really depends. Again, this is where the provider should retain healthcare counsel to review the MAO provider contract. There could be limited data rights. There may not be. There are, however, common law doctrines, depending upon the state you're in, that could be applicable to the situation, such as the implied covenant of good faith and fair dealing. So even if you don't have an audit provision that would allow you to allow you access to the data that you need, you could make a compelling argument in many cases that if you have a reasonable basis to believe that you're being underpaid, that equity, in effect, should require the MAO to produce data at least sufficient for you to be able to confirm that you've been paid correctly.
And I would just say that I think in any litigation involving risk adjustment diagnosis codes, if the contract does not have an audit provision, the MAO will certainly argue that you don't have the right to see the reports, but we can't guarantee, but we're substantially likely that a court would require these relevant reports to be produced in discovery by the MAO to counsel for the provider. So Jason, tell me, how do we verify MAO accuracy, MAO report accuracy?
Right. So there are sort of two ways, one being more optimal than the other. As I noted, once you're granted access to it, be it because the MAO has produced it or you've more likely recovered it through discovery in a litigation, you need to compare that data with the data from your in-house IT folks, and also with your clearinghouse folks. And if there are codes that are that are maintained in your practice that you sent to the clearinghouse that are not in the MAO report, you have an issue. Then look at the data that went from the clearinghouse to the MAO. Were those missing codes in there? If they were, then you know that the entity that lost the codes, I'll just use the term lost, was the MAO. And so alternatively, and this is only possible under certain circumstances, if you're in the litigation and the MAO is being totally recalcitrant, you could potentially seek to get the data directly from CMS, which is really the gold standard, because it's presumably untamperable and it's coming from a non-interested party. And that data compared against your clearinghouse data or your in-house IT data, that will tell you for sure whether or not and how much data has been lost. And from there, you can use your healthcare data scientists or actuaries to help calculate what the premiums should have been had those codes been properly submitted. And, you know, depending upon what we're talking about, it could be quite substantial.
Sure. Certainly depends on the patient population and premium amounts per member per month. So next slide, you know, Jason, we see that value-based care is definitely trending, and there's a lot more risk-adjusted compensation models. What does CMS say about these, and what are your thoughts on this?
Yeah, so CMS, you know, refers to these models as falling within population-based payment models, which is what a global risk capitated agreement is. And they have stated very clearly that they're interested in continuing the push from fee-for-service to value-based care, leading towards the final category, category 4. And in this snippet from CMS webpage, the citation we have there, they note that value-based purchasing includes payments made in categories 2 through 4. Category 2 is fee-for-service with a bump based on quality metrics. Category 3 can contain other alternative models that we don't really have time to talk about. Category 4 is what we're talking about today. And it says moving from category 1 to category 4 involves 2 shifts. 1, increasing accountability for both quality and total cost of care. And 2, a greater focus on population health management as opposed to payment for specific services. So I think CMS is going to continue to advocate for a wider adoption of this sort of payment arrangement.
So Jason,
and as I said, anecdotally, I'm aware of this potentially happening in the commercial space as well.
Not just Medicare Advantage.
Yeah.
So Jason, thank you for all that information. Before we go to any questions, and people can feel free to put questions into the Q&A. I want to thank you, Jason. I want to thank our marketing department for helping to make the slides a little more interesting. But I wanted some final comments. I think providers out there that are in, population-based payment models, they have to know that they have rights. There are healthcare lawyers out there, and there are also healthcare data scientists that can help put you in a better contract, that can help you understand the most important terms that you should negotiate in a contract. Once you're in a contract, providers should know there are lawyers that specialize in helping you make sure that you're getting paid all the dollars that you're supposed to be getting paid. There are trial lawyers that can protect you. There are, like I said, there are healthcare data scientists that work with lawyers that really ensure you're getting paid appropriately. So sometimes it doesn't I mention this because sometimes it doesn't feel like it's a level playing field. It's a little guy against a giant, some of these companies, Humana and other MCOs or MAOs, they're some of the biggest companies in the United States. And it doesn't always feel fair, but you should know that a decent contract coupled with federal rules of civil procedure and state rules really do level the playing field. And if you have a team that understands the space, you have the right to explore whether you've been paid properly. So I think we've answered most of the questions. I do want to thank those who joined, and we will provide the slides. And we do have our any questions, obviously. And here's our contact information. Mr. Silberberg is on here, and I am as well. And you can all feel free to reach out to us. We have offices in New York and New Jersey, and we really do look forward to hearing from people. And we wish you the best of luck. There's clearly trends moving towards this area, so you should know there's people out there to help. So thank you all very much for attending. Very much appreciated.